Heavenly Father, our healer, our protector, the object of love, the author of our hope, we surrender our lives before you today. Lift us up for your blessings. Anoint us with strength and peace. We lay before you our frustrations and doubts. Be our guiding light even in troubled times. May your healing hand rest upon those who are sick. May your life-giving powers help them recuperate, and that they may be able to restore their wholeness for your service. May you bless and guide those who continue to nurture us with care, knowledge, and love. We all pray these things in your holy presence. Amen.
Everything that flourishes, that becomes something greater, does so because of the singular gift of being nurtured. All the good, the true, the beautiful in the world has been touched by Amuma, or nurture. Just like a small blade of grass being completely nurtured, the radiant sun will come to grow as a lush garden by the wayside. Just like the chrysalis of a butterfly, nurtured by time, will come to transform into a creature with wings exquisitely patterned with vibrant colors emanating from its body. Finally, just like a beautiful baby girl, so innocent and pure, selflessly nurtured by her mother, will come to grow as a human person filled with gratitude, joy, and devotion to the world.
Kira ko ako lang di pangarap ang ako yung pamilya. Ito ang importante na ako akong pamilya. Kung ko lang di pangayos ginawa ako ang pamilya. Isang, dili na ko ganahan mga sa akong pagalingon. Ning ako, kontento na ako sa mga buwan. Basta wala lang may sakit. Madigid ay lalim na yung lima kabuk akong anak niya kami unong ako, 17 years old, namin ako. Pagpanganak na ako mga 20 yan ang Cyril. Yan na sa nagsugod ang mga problema. Sabi na masigi siya kasakit, mabakon, lanta niya. Mas kung sanay niya ang sakit. Nadayunin mo ko na ako ikaduha. Nga wako kibaw nga buntis da ito. Mga nasamid yun ang problema. May pagka 2012, nalaki sa ganang katulan ako. Ang ako ikalima kay padung pa magwan. Imagine na ako ang pangipangandi sa kong kinabuhi. Ako pa silang mahatagagwan ba ngayong kaugnaon. Pagpaibo pa nila. Ito pa dyan kong magtrabuhi kung sa kong mga anak. I'm 34 years old. Hindi ako lima ka na. Ako kayong problema sa kong kagalingan. Labi na niya akong sakit na kidney stone. Nakabati pa dyan nga bato kay stubborn. Pinakagahi na hilison.
Ni adtong 2010, nakasinati siya jutayng sakit sa iyang kilid apan iya lang kining gibaliwala. Setyembre sa miaging tuig pa niya kini napakonsulta sa doktor, humandi na niya maagwanta ang kasakit. Didto na nasuta nga aduna siya'y staghorn calculi.
Di pagbabasa na sa corpus, di medyo siya mahilis. Pabuli sa mga ano, wala na sa kugana ng liho, ng baon. Hila kong mayo, ay di ko padawat ba. Pila ka anlaw, maghinukto ko. Matambagan ko sa kumpare sa iyo, lagyan. Mulanto ko sa kong baby niya, labi na smile. Badi sila ito mag-uol kay ang akong bata na para badi ay labi na iya akong batawan. Ay, salamat ang Ginoo. Nakuha ko sa kong anak. Kaya ako sa kong balingon ba? Kaya magpa-lulong ko sa kong sakit nga. Naku, may chance nga mag-ayo pag-uro ko. Salamat ko nga, napatuloy ko sa kasal. Nagikauban na ako akong pamilya ka. Wala dyan ako niya sa hinalangan. Marami ako, Lord. Salamat dyan kayo sa pasugin. Kung nag-uptik sa akong lawas ka rin. Isag na ako sakit na didala-dala ka rin.
Unsa ang kidney stone o bato sa kidney? Ang kidney stone o bato sa kidney mao ang mga gahi nga nadepositong minerales o asid nga naporma sud sa imong kidney. Kitawag usab kini nga renal calculi, nephrolithiasis o urolithiasis. Sa 90 milyon ka mga Pilipino, posibleng anaa sa 2 milyon ang adunay kidney stones. Apan wa masayod nga anaa sila niini. Taas ang risgo nga magka-kidney stones sa mga lalaki kung mutungtong na sa pang-edarong 40 o padayong mosaka pa kini ngadto sa edad na 70. Sa mga babayi, mas nagkadaghan ang adunay kidney stones inigtungtong sa edad nga 50. Kung ang usa ka tawo aduna nay bato sa kidney, mas taas ang tsansa na mobalik kini o mas modaghan. Adunay nagkalain-laing klase sa bato na maporma sulod sa kidney. Una ang calcium stones, sumunod niini ang uric acid stones, cystine stones, o ang staghorn stones na moabot sa 10 hangtod 15% sa mga kidney stone. Mas common sa mga babayi ang staghorn stone kumpara sa mga lalaki. Sagad sa mga aduna niini, ang usa ra ka kidney ang apektado, apan posible sab na maapektuhan ang duha ka kidney. Staghorn calculi ang tawag niini kay susama sa sungay sa usa ka usa ang porma kun magkadako. Coral stone sab ang laing termino niini tungod sa susama sa coral sa dagat ang porma. Paspas mo dako ang staghorn stone sulod lamang sa pipila ka semana ngadto sa pipila ka mga buwan kung di igo ang pagtambal. Mas mutubo og mahimong sanga-sangang bato nga mopuno sa tibuok nga kidney. Ang staghorn ginatawag sad og infection stones tungod kay hugot nga may kalabutan niini ang mga urinary tract infections o infection sa agianan sa ihi.
When you say staghorn, it's composed of multiple horns, meaning one or two, more than 2 𝐀𝐦𝐮𝐮 involved na siya. That's called staghorn already. Staghorn stones, no, they don't cause obstruction. Ano na sila. Kung tubo siya hinay-hinay, filling the calyx. So imagine a mold, no, and then kay diha siya or mold sa imong kidney, diha siya motubo. It doesn't grow overnight. Ugay na gina siya. Katong ingon nimong 2012, duda ko na siya. So magdugo na siya kay ang stone nimo tungod dili pa man siya parado gyud, no? As I've said, dili siya mo para, pero mulihok siya.
Unsa ang mga risgo para magka-kidney stone? Usa niini ang pagsigig kaon og mga parat nga pagkaon, mga pagkaong taas sa oxalates sama sa mani ug tsokolate, mga pagkaon na taas sa uric acid sama sa seafood, sobrang pag-inom og vitamin C, ug ang kuwa nga pag-inom og tubig. Makaapektar usab ang taas nga timbang, laing mga kondisyong medikal ug mga tambal nga atong gipang-inom. Taas usab ang risgo kung aduna kay mga kaliwat nga nagka-kidney stone.
Graphical ato init man ta ata sa equator. Init nga area, no? Prone kay tag dehydration. O dehydrated ta, so prone ta mo form of stones and ana. Kaduha, kanang climate nga init sad. O sometimes kung dili sa kay tiglihok ang tao kana usasad na siya. Kahingin mo tubig, dehydrated siya ka. And then sa diet sa timo, foods with high potential renal acid load. high sodium intake, phosphate, carbonated, and helicare soft drinks. So the genetics would play a role. Naamoy kaliwat, kinay bato. Especially karong pandemic, kayo nag-overdose of vitamin C. Yung vitamins pa, too much. So, ang vitamin C limit per day is only 2 grams.
Particular sa staghorn, dakong risgo ang pagkasinati o balik-balik na UTI. Laing mga risk factors mao ang pagkababayi, edad, abnormal na istruktura sa kidney, dugay nga paggamit og mga catheters ug diabetes. Unsa ang mga simptomas sa mga tao nga naay kidney stones? Mahait na pagsakit sa kilid, likod, ubos nga bahin sa tiyan ug bugat. Pag-ihi og dugo, diin puwa o susama sa tsaa ang kolor. Kanunay pag-ihi, sakit kung mangihi, maglisod sa pagpangihi o gamay lang ang maihi. Laing sintomas mao ang pagsuka-suka. Kung staghorn stones ang hisgutan, posibleng wa unay mabatian ang usa ka pasyente, hilabi na kung wala pa kini moabot sa ureter o pasabot niini, wa pa mibabag sa agihanan sa ihi. Sagad sa unang sintomas kung ang tao may staghorn stones, mao ang urinary tract infection o UTI. Mamahimong makasinati sabga og dugo sa imong ihi ug hilana.
So, a lot of kidney stones are asymptomatic. So, if no imaging testing is done, it wouldn't be diagnosed. However, common symptoms of nephrolithiasis includes pain and hematuria. So, with regards to diagnostic imaging, we do not routinely do it unless if there is suspicion or we do surveillance imaging in patients with prior history of nephrolithiasis.
Unsaon pagkabalo nga adunay kidney stone ang usa ka tawo? Inisyal nga basehan mao ang pag-agi sa mga tests sama sa urinalysis ug urine culture. Diin makita ang mga gagmayng bato ug nitubong kagaw. Himong buhaton sab ang pagpa-ultrasound nga may plain x-ray sab sa tiyan aron masusi ang presensya sa kidney stones. Apan mas maayo kung moagi sa non-contrast computed tomography scan aron makumpirma ang kondisyon diin makita dinhi ang klase sa bato ug nagkalain-laing parte sa kidney.
Always do GFR scan to know the status of the kidney. So what is the purpose of getting the stone if your kidneys already has no function? To know the status of the renal function is very important in our management as to do outright nephrectomy or say the nephron sparing surgery and just get the stone.
Unsa ang angay buhaton kung naay bato sa kidney?
Calcium oxalate and uric acid stones, then you can give potassium citrate. You can also do alkalinization of the urine with the use of potassium citrate and sodium bicarbonate.
Adunay mga inisyal na antibiotics nga pwede mahatag para kini sa paglikay sa mga infeksyon o paglikay sa samot na pagdako sa bato. Angay lamang kini para sa mga pasyente nga dili angay operahan o mga dili mosugot.
Used to undergo surgically may be managed conservatively with medical therapy alone. However, medical therapy alone is rarely successful. There are no randomized trials comparing surgical with medical therapy for the treatment of staghorn calculi. But several observational studies have suggested that conservative therapy compared with surgical therapy is associated with higher mortality and progressive deterioration of kidney function. So, patients with evidence of concurrent UTI should be promptly treated with antibiotics and is considered under acute complicated pyelonephritis. Approach to empiric therapy would depend on the severity of the illness, the risk factors for resistant pathogen, and specific host factors. It's usually the struvite and the staghorn calculi. Other indications for urologic consultation, patients who are with urinary tract infection or acute kidney injury or the presence of anuria and those with unyielding pain.
For staghorn, actually there's no curative oral medicine that pwede matter for staghorn. It's already staghorn, the stone burden is too large to resolve yet. So we do medical management for stones less than 1.5 to 1 cm. No? We medical expulsion or medical dissolution. Pero sa staghorn, dili na. So we're just preventing the stone to grow bigger. Ito ang goal na maghatag sa tambal. So the mainstay of management is always surgery. There's options of management, no, for renal stones, no. Firstly, we can always do the conservative management. So as I mentioned, medical dissolution therapy, so using oral medications, no, for stones less than 1.5 or 1 cm. For stones bigger than that, we have the option of shockwave, extracorporeal shockwave lithotripsy. It's an outpatient procedure. Another option would be endourology, so ureteroscopy, intracorporeal lithotripsy. Another option, we can have retrograde intrarenal surgery. And another option is katong PCNL, percutaneous nephrolithotomy. Ask, magilis ba ni? For stones less than 1.5 or 1 cm, we can do medical dissolution therapy. Meaning, tambal para mo, magilis ang dako. Kung sa may ito ang buhato na ni, katong mong laser or endoscopic, we can do endourology. Walay hiwa. Really 100%, makurot na to in one operation. Alternative for remote is katong hiwa kung dyan siya, ang tangon. We call this the anatrophic nephrolithotomy. Meaning, kamo gini siya buhaton ng kidney. Or hiwa ko na mo, i-bival na ng kidney para makuha na mo ang bato intiro.
Ato susihon ang nagkalain-laing klase sa opera sa kidney stones. Mga klase na pag-opera sa bato: shockwave lithotripsy, percutaneous nephrolithotomy, ug anatrophic nephrolithotomy. Ang ginatawag na shockwave lithotripsy makawagtang sa bato na mas gamay sa 2.5 cm ug angay sa mga batan-on. Ang percutaneous nagpasabot pinaagi sa pani. Ang nephrolithotomy nagpasabot nga kuhaon ang mga bato gikan sa kidney. Kini usa ka minimally invasive nga pamaagi alang sa mga bato sa kidney nga mas dako sa 2 cm ang gidak-on. Ug kini ang gold standard para sa mga dagko na bato sa kidney. Ani nga operasyon, usa ka gamay nga teleskopyo ang ipaagi sa tubo aron makita ang bato. Mabuak kini ug makuha kini gikan sa lawas. Anatrophic nephrolithotomy. Lain usab kini nga pamaagi aron makuha ang bato sa kidney. Kini usa ka open surgery alang sa mga komplikado ug dagkong staghorn calculi. Kung diin, dako nga hiwa ang himuon aron ibutyag ang kidney ug makuha ang bato.
Eventually, they will have to. The stone will grow bigger and then occupy, and then it will make the kidney less functioning. It will become non-functioning, and ang patient may uremic na. So if you don't do that, tantangon na lang gina siya. You might have to do nephrectomy.
Unsaon man ni paglikay?
So preventive measures for all stone types include sufficient oral intake to consistently produce 2 liters of urine per day. And the other one is diet and lifestyle modifications such as low sodium intake, increase of intake of fruits and vegetables, adequate dietary calcium supplement, again dietary calcium and not calcium tablets, reduce the intake of animal protein, limit foods rich in oxalate, and also weight loss is a good preventive strategy for the prevention of recurrence of kidney stones.
Ang paghimo o gagmay nga mga pag-adjust sa imong kasamtangan nga pagkaon o plano sa nutrisyon mahimong makatabang sa pagpugong sa mga bato sa kidney. Pag-inom og daghang tubig, mga 8 ka baso kada adlaw, kaon og daghang pagkaon nga taas og calcium, pagminos sa pagkaon og mga parat, mga pagkaon na taas sa oxalate sama sa mani ug tsokolate, ug mga pagkaon na taas og uric acid sama sa seafood o atay. Likayi ang sobra nga pagtumal og vitamin C supplements ug pagmintenar og saktong timbang.
Para sa pasyente nga adunay staghorn calculi, dili igo ang medical therapy lamang. Ang operasyon ang pinaka-epektibo nga solusyon. Apan dako o gasto ang pagpaopera, hilabi na sa mga pasyente na walay igong kwarta para niini sama ni Ma'am Cora. Kinsa o asa man sila pwede moduol para sa pinansyal na tabang.
Ang Malasakit Center usa ka one-stop service center sa mga nagkalain-laing ahensya sa gobyerno nga anda mohatag og medikal ug pinansyal na suporta sa mga labing nanginahanglan. Ang mga ahensyang naglakip ay ang Department of Health, PhilHealth, Department of Social Welfare and Development, Philippine Charity Sweepstakes Office, ug Philippine Amusement and Gaming Corporation. Sa Metro Cebu, makita ang mga malasakit centers sa Vicente Soto Memorial Medical Center, Cebu South Medical Center, St. Anthony Mother and Child Hospital, Lapu-Lapu City Hospital, Eversley Child Sanitarium and General Hospital, ug Cebu Provincial Hospital sa Carcar City. Unsa ang tumong sa Malasakit Center sa paghatag og serbisyong medikal?
Malasakit Center is based on the passage of a law which was signed by President Duterte, the Republic Act 11463, which aims to help all persons, especially in the health facility setting, in relation to their medical needs, be it medicine, hospitalization expense, meaning the hospital bill, blood, and anything that is in relation to their medical case.
Unsa ang mga serbisyo na ginahatag sa Malasakit Center?
It's not the institution itself. There are partner agencies within. Before, patients used to go to different agencies to ask for assistance. With the Malasakit Center, when they enter, these agencies that used to be giving medical assistance are now within the center.
Kinsa ang mga makabenepisyo sa mga serbisyo sa Malasakit Center? Pwede ba kini madawat sa mga pasyente sa outpatient department o sa mga na-admit lamang kini?
So specifically for Vicente Soto Malasakit Center, is our patients are admitted or those seeking consult at our outpatient department.
Unsaon pagpakahimulos sa mga serbisyo sa Malasakit Center? Unsa ang mga rekisito nga kinahanglan para makapahimulos sa maong serbisyo ug unsa kadugay ang proseso?
There are participating agencies. So each participating agencies sets their own monetary requirements. It depends on the type of assistance that is provided to a particular patient. But the most basic one is they have to be consulted first at our outpatient department and must be seen by a doctor. There are medical needs prescribed by the doctor, and also a patient that needs to be seen at the ER and advised to be admitted in our health facilities. It doesn't take that long. The longest siguro mga 30 minutes to 45 minutes. But this depends on the number of patients that are accessing Malasakit Center.
Libre ra ba ang pagpahimulos sa mga serbisyo sa Malasakit Center? Kung dili, naa ba kini bayranan?
As long as it is available in our health facility, ma'am, it being provided free of charge. As long as they also comply with the requirements and it is being prescribed by our doctor, excluding professional people if there is any. There must be an admitted case or an outpatient case. For our admitted case also, we only provide assistance for those charity or service cases.
Pag-implementar sa Universal Healthcare Law, unsa ang epekto niini sa mga serbisyong medikal nga ginahatag sa PhilHealth ug Malasakit Center?
The Malasakit Center is part those that make Universal Healthcare Act a realization, no? Because it attends to the medical needs of the needy and poor patients. Accessibility as to healthcare are being addressed by Malasakit Center. So actually, it complements or it completes the Universal Healthcare Law.
The patient's condition cannot be taken in isolation, but rather both medical and psychosocial aspects of the patient's predicament may affect the impact of the disease and should be considered when planning the delivery of care. The PFC matrix is a method of patient case analysis that integrates the biopsychosocial information gathered to come up with a holistic management of the patient. Here, I will present the family PFC matrix of the family of our patient. PFC stands for Patient-Centered, Family-Focused, and Community-Oriented Matrix. These are further subdivided into data gathering, analysis, assessment, and management. For patient-centered approach, it utilizes the understanding of the interplay of biomedical and psychosocial factors in order to implement management that is tailor-fitted to the needs and values of the patient. For data gathering, we start with a biomedical history. Cora is a 34-year-old female, single, unemployed from Barangay Pacnaan, Mandawi City. The patient is a known hypertensive and was diagnosed last 2021. Patient's highest recorded blood pressure is 160 over 100 millimeters mercury, with a usual blood pressure of 110 over 80 millimeters mercury. She is maintained on telmisartan, Praecordia, 40 milligrams per tablet, 1 tablet orally once daily after breakfast, which is taken with poor compliance. The patient is also a known asthmatic since 2000, with last exacerbation in 2019. The patient is a G6P5 5015. Patient's menarche was at 13 years old. Last menstrual period was March 19, 2022. Patient has no history of sexually transmitted infections, no HPV vaccinations. Her educational attainment is up to first year high school and is currently a housewife. Patient is a non-smoker, non-alcoholic beverage drinker, and denies the use of illicit drugs. She has a preference for salty, oily, fatty, and spicy food. She usually skips breakfast and lunch due to her being occupied in attending to her children. Hence, she does not eat on time. She drinks 1 to 2 liters of water a day. She voids about 10 times per day, with varying amounts depending on her fluid intake. Sometimes approximately half a glass with light to dark yellow cloudy urine. No dysuria, hematuria, nocturia noted. No changes in bowel habits. She sleeps approximately 4 hours a day. Activities of daily living include taking care of her children and doing the household chores. The skin, the HENT, the neck, the breast, and the chest and lung findings were all unremarkable. Cardiovascular system revealed an adynamic precordium, normal cardiac area of dullness, distinct S1 and S2, regular rate and rhythm, no murmurs. For the abdomen, there is positive tenderness and deep palpation at the right and left flank radiating to the back. No palpable masses. The kidneys are palpable, and there is a negative Murphy's sign. Digital rectal examination revealed the presence of an anal skin tag, approximately 1 centimeter in size, located at the 11 o'clock position at the anal verge. For the back, there is positive costovertebral angle tenderness bilaterally. For the extremities, there are no deformities, no edema of upper and lower extremities. CRT is less than 2 seconds, and there are strong peripheral pulses. For the neurologic examination, cerebral, cranial nerves, cerebellar, sensory, motor, and reflex findings are all under normal limits. On the patient-centered analysis, it was revealed that aside from her medical condition itself, the patient also faces psychosocial issues, such as poor health literacy and familial understanding of her illness, fear in seeking consultation. Economic issues also make an impact. An example is the difficulty in accessing healthcare services due to financial constraints. These psychosocial and economic issues are part of the problems that need to be addressed for holistic management of the patient. For the patient-centered assessment, the diagnoses are the following: staghorn calculi, right kidney, and primary hypertension, stage 2, controlled. A renal GFR scan is a test that shows the function and blood flow of the kidneys using a radioactive tracer. The amount of radiation used in this test is small and well within the limits that are not harmful to us. The patient will be given a small amount of radioactive material intravenously. Then, a special camera will be used to detect the tracer and take pictures of one's kidneys. The results revealed a normal-sized right kidney with a normal overall total GFR at 81.6 milliliters per minute, but with decreased parenchymal function and a possible obstructive pathology in the right kidney. The left kidney was unremarkable. Complete blood count showed no anemia, and the WBC differential count showed no infection. Blood coagulation parameters were within normal limits. An electrolyte panel was ordered, composed of serum ionized calcium, phosphorus, potassium, sodium, and magnesium. A pertinent finding was the low serum potassium. Hence, the patient had hypokalemia. A lipid panel was done and revealed a high level of very low density lipoprotein. A fasting blood sugar was done and was within normal limits. Urinalysis was done and revealed hematuria, pyuria, abundant bacteria, and a positive nitrite test. This indicates a urinary tract infection. A 12-lead ECG was done and revealed sinus rhythm with non-specific ST changes on the inferior lead and the presence of U-wave. The ECG reading shows no evidence of cardiomegaly or heart failure. At this point, we now proceed to the therapeutic management. For our patient's condition, the definitive therapeutic is a surgical stone removal in the form of anatrophic nephrolithotomy. Anatrophic nephrolithotomy is a type of open surgical procedure for stone removal. This is used most commonly to manage patients with extremely large stones and complex collecting system anatomy. This is performed with a patient in the flank position. A parenchymal incision is made in an intersegmental plane, allowing the removal of large renal calculi such as staghorn stones. For the pharmacologic management, we gave ciprofloxacin 500 mg per tablet, 1 tablet once a day for 7 days for the patient's UTI, and potassium citrate 10 mg per tab, 1 tablet 3 times a day for the patient's hypokalemia. Non-pharmacologic management includes follow-up imaging and periodic urine culture after surgery at 6 to 12 months. To increase water intake at least 2 liters a day. To increase intake of calcium-rich foods and low phosphorus and oxalate diet in the patient's diet. To prevent the recurrence of UTI, the following should be done. First, the practice of post-defecation and anal cleansing anteroposteriorly. Post-coital urination. The avoidance of tight-fitting underwear. And the use of alternative form of contraception. For the patient's primary hypertension, we continued her maintenance medication, telmisartan, micardis, 40 mg per tablet, 1 tablet once daily after breakfast. Non-pharmacologic management includes reduction of sodium intake, diet modification, moderate consumption of drinks high in sugar, coffee, or tea, exercise, weight reduction, blood pressure monitoring, moderate alcohol consumption, reduce stress and induce mindfulness, educate about consumption of food or herbal supplements, appraised on the complications of hypertension, and lastly, reduce exposure to air pollution and cold temperature. Next is a family-focused approach of the PFC matrix. Family-focused approach utilizes family assessment to generate assumption on how the family dynamics affect or facilitate the prescribed management of the patient's disease. First is the family profile. The Javier Martinez family is a nuclear family composed of the index patient, her common-law husband, and her 5 children. Her partner is the main income provider, decision maker, and primary caregiver of the index patient. The index patient's family is currently in stage 4, family with adolescents. First-order changes evident in the family include sharing the tasks or responsibilities of family living, such as doing household chores and taking care of younger siblings. Another first-order change is maintaining contact with their extended family regularly, either through phone calls or meeting up for meals in their home. Second-order changes include shifting of parent-child relationships to permit their adolescent children to move in and out of the system. The index patient and her partner also need to refocus on midlife, marital, and career issues. This stage would also shift concern towards the older generation, since both their parents are getting older as well. This is the family genogram of the index patient, consisting of 3 generations. Notable here is the strong family history of hypertension and asthma on the maternal side. 4 out of 5 of the children are diagnosed to be asthmatic as well. The Javier Martinez family lives in their 2-story house, made up of both light and concrete materials, situated within a government-owned land. Their home only has 1 bedroom, which is occupied by all 7 members of the family. It is congested and poorly ventilated, with only 2 doors acting as their windows. The family's current income comes from the earnings of the index patient's common-law husband as a motorcycle driver with a sideline as a laborer in a factory once to twice a month with a total income of approximately 15,000 per month. 70% goes to food, followed by 12% for formula milk of her youngest child. The rest are used to pay for basic needs and bills, leaving only 5.3% for medications, not even having enough savings for medical emergencies. The analysis of Apgar 1, the family, shows that Cora, Carlo, and Carmen consider their family to be highly functional. They rely and turn to each other during trying times. They freely support each other in terms of wants, needs, and hobbies. They are all expressive and affectionate and are satisfied with how they spend time together as a family. Family Apgar 2 shows that the index patient gets along well with all members of the family. Family circle, Cora, the index patient, is close with her immediate family, mother, siblings, as well as her best friend, who are all equally loved and important to her. The family map is a tool designed to reflect intrafamilial relationships and interaction patterns. Cora and Carlo, both as parents, have functional relationships and clear boundaries with their children. Their relationships have clear boundaries except with Camille, her youngest, who still relies on her and hasn't adopted responsibilities in the family just yet. All of their children have functional relationships with each other. The heredofamilial diseases include hypertension and asthma on the maternal side, and the relationships between family members is highly functional. Continuing, the family is in stage 3 of the family illness trajectory because she was diagnosed and compiled all her prior laboratory results and was determined to get in contact with CIM-CMSS to have herself treated. She was assisted on her application for the Malasakit program at VSMMC, where she can avail of the health services with discounts or free of charge. The Smilkstein cycle reflects pathways of the response of the family to stressful life events. Using this tool, the family is noted to be in crisis, brought about by her diagnosis. Despite the intrafamilial resources, such as the husband's income as the habal-habal driver, and strong emotional support and interpersonal relationships within the family, and their extrafamilial resources, including the Mandaue City LGU, DSWD, CIM-CMSS, and extended family, these resources were inadequate to bring the family back into equilibrium. Hence, they are a family in crisis. For the management of the family-focused approach, a family meeting using the CEA method was done last May 16, 2022 to address health misperception. An income-generating project for livelihood intervention was also started. And finally, a wellness plan was prepared for each family member. Lastly, community-oriented approach enables the use of social determinants of health and health systems as a lens to understand how larger systems support or hinder the provision of care. For the family eco-map, in times of crisis, they turn to their families and neighbors for extra-familial resources. They were also able to tap different agencies and institutions such as the CIM-CMSS, along with the consultants, residents, and clerks, and PGIs by which consultation was done. The Malasakit program for previous CT scan result, their barangay, and their church for food and assistance, DSWD for financial aid, and lastly, Patnaan National High School and Elementary School for the children's basic education. Meanwhile, these are the agencies and institutions present in the community but were untapped by the patient due to lack of awareness. This includes PhilHealth, PCSO, Pag-ibig, and lastly, the Social Security System. The SCREAM Family Assessment Tool revealed, firstly, for the social aspect of the family, they are able to communicate with family members when problems arise. Second, they are able to turn to neighbors in times of need. Third, they are able to share her problems with her closest friends. However, a pathology in the social aspect of the community are not on speaking terms with one of their relatives due to some misunderstanding. For the cultural aspect, their resources include having strong family ties, which help them get through troubles as a family. The family shares all the responsibilities and roles in the household, and they show respect for each other's opinions. No cultural pathologies were found. For the religious aspect, the family is Roman Catholic and has strong spiritual beliefs. They turn to prayers during hard times and shows gratitude when the problem resolves. This means that their faith is a source of strength in difficult times. No religious pathologies were found. For the economic aspect, the family is able to borrow money from relatives and neighbors. There are several pathologies, including the monthly income of the father is barely enough to sustain their basic needs. The family has no emergency funds for urgent or emergent situations. Both Cora and her husband have limited job opportunities due to poor educational attainment. The family wants Cora's medical condition to be treated, but cannot do so due to financial constraints. For the educational aspect, the family sees and values education as important in order to get a good job. Carlo and his children can grasp concepts and understand their mother's condition when provided with proper education. However, the family's medical knowledge and understanding of Cora's condition are limited due to their low educational attainment. For the medical aspect, a resource is the family's ability to know the closest health facilities and outpatient clinics. However, despite this knowledge, the family at times does not avail of government health facilities and instead goes straight to private facilities. Moreover, they could not afford to do laboratory examinations due to financial constraints. Cora also has no PhilHealth membership. Furthermore, Cora has a lack of knowledge regarding her condition, leading to poor health-seeking behavior. Method analysis, a fishbone diagram was made. We identified the delayed disease diagnosis and management as the root cause of the patient's problem. Factors that contributed to this root cause are the following: poor health literacy, low socioeconomic status, poor health-seeking behavior, inaccessibility to healthcare services, and lastly, underutilized government programs. The community-oriented assessment, we identified that the community has generally poor health-seeking behavior that commonly leads to delayed disease diagnosis and management. There's also prevalence of poor health literacy. Underutilization of government health programs such as the Malasakit program, PhilHealth, and others are also apparent. They're also unable to afford the cost of consultation and treatment. And lastly, there's widespread use of alternative medicine. With the community-oriented management, assistance is given in accessing extra-familial resources for health services, specifically for the application for indigency of PhilHealth membership and linkage to the Malasakit program. We will also employ an information campaign via the installation of tarpaulins or distribution of brochures containing information regarding government health programs and the services they offer, placed at strategic locations within the community. We will also present an infographic regarding staghorn calculi online. Lastly, we will present our CSC video on Facebook Live with a target audience of 200 to 300 viewers. This will provide information on the epidemiology, pathophysiology, and management of staghorn calculi through video presentation using lay terms. Through this educational discussion, we aim to promote good health-seeking behavior within the community. This is Amuma. Thank you very much for watching.
Daghang salamat.
Burning upon some hidden cloud across the darkness one night, we saw a shining light, a love that is unparalleled, made of unwavering devotion and sacrifice, coming from the most familiar voice and touch, who knows the nooks and crannies of our hearts. We call that person Mom, Mama, Mother, Nanay. A mother's love is bliss. It need not be acquired. It need not be deserved. She is the lighthouse in the dark mist of the storms, shining her beacon of light across the hazy skies. Her light shines big and bright all throughout the night until daybreak and the sun shines. She will stand alone in the dark, guiding you always with the light. Siya ang mag-amuma.
Akong mama kay selfless.
Teacher. Mabinuligo.
Severe.
Heroine.
Mapagmahal.
Powerful. My mom is strong.
My hero. Guardian.
Warrior.
Orb.
Ang inahan para kanako atiman ug mo guide sa iyang anak.
Tambal.
Inahan.
Inspiration. Tinakap. Bulawan.
Para ko mama, atiman rin ka na ako.
superhero.
Love.
Survivor.
A fighter.
A great provider.
She is loving.